So we're in a fortunate world with relapsed refractory myeloma where we have a number of different treatments coming through. Within the BCMA class, we have antibody-drug conjugates, we have bispecific T-cell engagers, and we also have CAR T-cell therapies. But clearly, there are two different types of antibodies within the BCMA class, the bispecific antibodies and the antibody-drug conjugates. And the question we often get asked is, how do we select between these two classes of treatment? The first thing to say is that both of these treatments are effective in patients who are triple class exposed, and so you should be definitely thinking about these treatments across both. In terms of how to select the patients, well, they have very different side effect profiles, and that's going to help guide you. With the bispecific T-cell engagers, the predominant adverse event is cytokine release syndrome, neurotoxicity, and patients are required to be hospitalized for the initial step-up dosing due to those adverse events. Whereas with belantamab mafodotin, this is an off-the-shelf antibody which does not require any hospitalization. It is a single infusion which is given every 21 days, whereas the bispecifics are often weekly or fortnightly. However, with the belantamab mafodotin, there are ocular side effects which lead to blurring of vision and impaired visual acuity. So the patient needs to see an ophthalmologist before every dose. So what you can see is that they're quite different. Patients with bispecific T-cell engagers will have to commit to a hospitalization and need to be fairly robust to be able to tolerate cytokine release syndrome, whereas you can easily give belantamab mafodotin to a much frailer patient. The flip side of the coin is belantamab is now being combined, and once you combine it with standard of care agents, then the response rate becomes almost equivalent to the bispecific T-cell engagers. So I think it's really a case-by-case basis with the patient. You need to work out what will suit the patient. You need to work out the aggressiveness of the disease. With a highly aggressive disease, the T-cell engager works very well, whereas with belantamab mafodotin with monotherapy, the response rate is much lower, and so these are the multitude of factors that you need to bring in when trying to consider which way to go.